Hello and welcome to your postpartum lecture. So we have spent the last few weeks talking about preparing for pregnancy and all the changes that occur. Now we are going to reverse that whole entire process. So we're going to discuss the head to toe assessment for a non-pregnant female. Let's go ahead and start with blood volume. If we know we increase our blood volume by 50% during pregnancy, what do we need to do now that we are no longer pregnant to decrease the blood volume? How do we get rid of all that excess fluid? And think about all the fluid shifts that take place, the third spacing during pregnancy. Either they had preeclampsia and they got edematous. Some pregnant patients get edematous in their feet and lower extremities just from prolonged standing and all the venous pressure from gravity of the baby. Um, Moms receive a lot of fluid boluses or hydration during labor. And so they need to get rid of all this fluid after they're no longer pregnant. One of the ways that moms get rid of all this fluid is their kidneys. So preeclampsia also affects this because remember, with preeclampsia, your kidneys don't function as well. And so that may take those moms a little bit longer for all this fluid to leave their system and diurese. So during the postpartum period, moms diurese like crazy. They have lots and lots and lots of urine. And the most important thing about a postpartum assessment is their uterus. So usually your uterus, it's still going to contract to get back to its normal size post-pregnancy. Involution, typically it goes down by 1 finger breadth per day. So at delivery, it's usually at the umbilicus, and then day 1, 1 below, day 2, 2 below, and so forth. How it is written is U is umbilicus. 1/U or 1 above U is 1 finger breadth above the umbilicus, and then 1/(-1) is 1 finger breadth below. And that's how we document it in our documentation at work, and that's how we describe it. We'll say 1 below U when we're giving handoff or shift change report. So when we're talking about bladder being the bully, why do you care about a full bladder on a pregnant patient? I know we spoke about this before, but when your bladder's full, it's going to push up on your uterus and displace it. Usually it will deviate to the right. When the deviation occurs and it's displaced, then that prevents the uterus from contracting adequately. And when your uterus doesn't contract, that's what we refer to as uterine atony, where your uterus gets soft. It can lead to a postpartum hemorrhage. So because moms are diuresing a lot and have a lot of output in the postpartum period, their bladder can fill up more quickly. And so it's very important that you educate your patients that they need to get up and empty their bladder every 1 to 2 hours to prevent it from getting full. Now, sometimes moms, especially if they've had an epidural or with C-section, they'll have a spinal. Usually they have a Foley catheter or indwelling catheter in place with the C-section for at least 12 hours. But sometimes these moms can have difficulty urinating after that catheter comes out, as well as those moms that have had epidurals from the anesthesia, just relaxing everything, and it might be difficult for them to urinate on their own. So if moms have up to 6 hours to urinate after they have delivered vaginally, if they did not have a C-section with a Foley in place but got an epidural, or those moms that have had a C-section, 6 hours from the time the catheter is removed is the time period we give them. If they aren't able to avoid on their own during that time, then we will have to straight cath them to empty their bladder. And diuresis typically starts within 12 hours after birth and can last up to 1 week postpartum. For preeclamptic patients, sometimes it takes a little bit longer because they do typically have more fluid on board. So it could be even up to 2 weeks or even up to 3 weeks postpartum for them to get all that fluid off. Fundal checks are very important. When you're doing a fundal check, the nurse is cupping the one hand at the top of the fundus, and then they want to always support the lower uterine segment. If you don't provide that support because the muscles and stuff are weakened from delivery, sometimes you can have a uterine prolapse, and you don't want that to happen because that can also lead to postpartum hemorrhage as well. After pains, that's what we're referring to as you're still contracting, your uterus is still clamping down and getting back to its normal size. So moms will still have contractions after they deliver their baby. When we're talking about after pains being worse for multiparous women and when breastfeeding releases oxytocin. And so oxytocin, remember, we give that to prevent a postpartum hemorrhage. It's one of the medications we use. And it also is given during delivery for an induction because it causes contractions. So when you're breastfeeding, moms release um, oxytocin, and that's causing their uterus to contract more and can cause a lot of menstrual-like cramps for moms. Also, multiparous, meaning you've had multiple pregnancies and deliveries. So when you have multiple pregnancies, each time you get pregnant, your uterus is getting stretched. And so sometimes your uterus has to work a lot harder if you've had multiple pregnancies to get back to its normal size. So those moms that are multiparous, meaning 3+ deliveries or pregnancies and deliveries, they are going to have more pain than those who are first-time moms or even second-time moms. So sometimes these patients, we typically only give Tylenol or ibuprofen for pain control for vaginal deliveries. But these moms, because they do have a lot more pain following birth, they sometimes will give them oxycodone or Percocet, some of the stronger narcotics, because of their pain. And it typically takes about 6 weeks for your uterus to return to its pre-pregnancy state or size. So what is lochia? Lochia is referring to the vaginal bleeding that a patient has following their delivery. It's important that when you're massaging the fundus, that you're also visually inspecting how much lochia is coming out. So sometimes when the mom has been laying there and you're massaging the uterus, it's normal for a small amount of bleeding to come out. But what you want to make sure is that they're not passing clots, that they're not continuing to bleed every time that you're massaging the fundus. So you might have a couple little trickles, but you want to make sure that they aren't continuing to bleed or passing clots during this. That could indicate that they might have a laceration or a tear or retained products in the uterus, something else, if they continue to bleed. So typically in the first 3 to 4 days after birth, it's going to be bright red in color, and that's what we call rubra. And then once you get around day 4 up to about day 10, you're going to have serosa, where it's starting to turn pink, pinkish brown, and it's getting lighter over time. And then 2 to 4 weeks following delivery, it turns from the pinkish brown to more of a yellowish white or whitish color. Patients can typically bleed anywhere from 2 to 4 weeks postpartum. It's kind of like your menstrual period, where it starts out heavy and it gradually slows over time. Clots can be normal during the initial few days, but small size clots like pea size or dime quarter size. If you have anything larger than a golf ball, then that is too much bleeding, and we wouldn't expect that for a normal uh, vaginal delivery. Also, if they're saturating a pad in an hour's time, and they do that for 2 consecutive hours, that's considered too much bleeding, and you'd want to call and let the physician know. It is normal for a mom who has been laying in bed for a while and then they get up to move around or go to the bathroom to have a little bit more bleeding, and increase in their bleeding, because it's just been sitting inside and it's coming out. Also, with breastfeeding, that can increase the bleeding as well, because remember, I just talked about oxytocin and it causing contractions and helping prevent postpartum hemorrhage. So when your uterus is contracting, you might have a little bit more bleeding gush out every once in a while. So episiotomy used to be a thing that all the physicians would do for every single patient who was having a vaginal delivery. They just went in and snipped everybody. That has kind of gone by the wayside. It's not evidence-based practice anymore. They don't routinely do episiotomies for every patient. It is better to let them tear on their own, because their tear or trauma that was caused down there heals a lot better, less risk of infection versus having an episiotomy, and it's less painful as well, because sometimes when you have, might be just a superficial tear and not go through all the muscles and tissue like when they cut during an episiotomy. So if a patient were to have an episiotomy for whatever reason, if you had a shoulder dystocia, sometimes a doctor will do a small episiotomy to help make more room for the newborn or the baby's shoulder to be delivered, and so they will do this. You want to make sure that you're inspecting any tearing, lacerations, anything that they had repaired. And what I mean by repaired is they will suture the tears or lacerations closed. The sutures dissolve on their own, so there's no special care that the patients have to do with those, but you want to make sure that it's not getting red around the sutures, there's no edema, ecchymosis, any discharge, and that it's approximated that the sutures are still intact. It's also important to teach patients, if they have a tear that was repaired or a laceration or episiotomy, about proper peri-care, and that they're using the peri bottle to cleanse the area, keeping it clean and dry, changing their pad every time they get up to go to the bathroom and putting a fresh one on. And that when they're wiping, that they're just patting very gently and lightly so that they don't tear those sutures open. And this is what I was talking about with the peri-care. The little squirt bottle here on the bottom, we'll fill it up with warm water. Patients are instructed every time they get up to go to the bathroom to rinse off with that and then pat dry instead of wiping. There are some other products having lacerations or tears, or even an episiotomy can be very painful, and even just having vaginal delivery without a tear or laceration, some patients can get hemorrhoids because of all the pushing and straining that they were doing during the delivery, and those can be very painful as well. The witch hazel pads or the Tux pads, there's Dermaplast spray. Those are all, Epifoam is another one. All measures or interventions that we can give to the patient to help with their pain and provide them more comfort. So they will use the peri bottle, pat dry, and then they can put the witch hazel pads on the top of their pads and then use the spray every time after they go to the bathroom. Another thing that also helps with Comfort, because a lot of times having a vaginal delivery will cause you to have swelling or edema, and ice packs can help with that. Sitz baths is another thing, comfort measure that we can provide to the patients. With the ice packs, they're only good for the supposed to be used for the first 24 hours, and then after that they're not going to cause much benefit. So we kind of covered the whole postpartum assessment at one of your clinical days, where you're inspecting their breasts, making sure that there's no infection going on, that their nipples aren't cracked and bleeding from breastfeeding if they are breastfeeding. The uterus is probably one of the most important, that you're checking that and massaging it to make sure it's firm and not boggy. Their bladder, you want to make sure that they're going to the bathroom frequently to prevent postpartum hemorrhage, and that they are able to void on their own. Lochia, so you're assessing their vaginal bleeding. If they had an episiotomy, a laceration, or a C-section incision, that you're inspecting that to make sure there's no redness, edema, discharge, that the incision is approximated. And then emotions, and we'll talk about that, and the extremities in a little bit, where you're checking for DVT. The sitz baths we don't commonly do anymore, but it's a little bowl that you fill with warm water, and the patient can sit in that, and that kind of helps provide comfort. When we're talking about hemorrhoids and checking to make sure, or seeing if they have hemorrhoids, you also want to make sure to provide patients with stool softeners after, especially moms who had C-sections, because of all the narcotics that they are receiving. So here are some of the postpartum complications that can occur. You can have mastitis, which is a breast infection. Sometimes you can get an upper respiratory infection. Typically those and the UTI are more common for moms who had a C-section. Thrombophlebitis, also endometritis is an infection in the lining of the uterus, which can occur with both vaginal and cesarean sections. Hematoma or abscess formation in the perineal area. Risk factors for some of these complications are the C-section, prolonged rupture of membranes. If they got chorioamnionitis, sometimes that can get into their uterine tissue, and that can lead to endometritis or perineal cellulitis. Prolonged labor, bladder catheterization, and if they had a postpartum hemorrhage, they can have further complications because of that. As I mentioned before, with the C-section, they're going to have the Foley in place. It is removed after 12 hours unless it is contraindicated. So what are some of the reasons why it might be contraindicated to remove it in that 12-hour period? So if you have a mom who has a Foley catheter in place, you notice their Foley's not draining very much, they have very little urine output, there's blood in their urine, or if they were in a CRETA and they had bladder involvement and had to do repair on the patient's bladder, those patients will go home with a catheter in place, usually for the first week or two, to allow the bladder to heal. If the patient is in a lot of pain and they're dizzy, or they're lightheaded when they get up to move around, or they haven't been up to ambulate, you want to make sure that the patient's able to ambulate and get up and go to the bathroom before you remove the Foley. So those are some things why you wouldn't remove a catheter for a patient. If you ever question whether you should or not, don't hesitate to call the physician and be like, hey, this patient's only had 50 cc's out of her, or out in her catheter since delivery. What do you want to do? Do you want us to give her fluid bolus, keep it in, and make sure that they come and assess the situation before you take out a catheter on a patient. So the NCLEX likes to test you on perineal tears and lacerations. A first degree is a perineal tear in the tissue. Once you get through the perineal muscles, it's a second degree. And then once you disrupt the anal sphincter, that is where it becomes a third degree. And once you enter the anal capsule, that is a fourth degree tear. So basically, there is no barrier between the rectal tissue and the vagina. Can you imagine how painful that is? If these do not heal properly, a vaginal or anal fistula can occur. Also, sometimes because of the tear and weakened muscle and tissue, rectal and vaginal prolapse can occur later in life as well. Usually moms will feel like a burning pain or sensation during crowning when the fetal head is crowning. And that is usually when their tissue and muscles are stretching. And that's where the tears typically occur during the time when the baby's head is crowning. There are some interventions that the physician can do or tell the patient to do to prevent this. Mineral oil, sometimes the doctors will put, put mineral oil on their skin to help tell the patient to slow down or pause a little bit during their pushing. Breathing, don't push as hard, so less pressure. And then sometimes the physician will go around just like he's doing a vaginal exam and kind of help stretch the tissue before the head comes all the way out. This sometimes you can have a cervical laceration that works its way up a tear or disrupt a uterine artery. Cervical lacerations are rare, but they do occur if the mom starts to push before she's fully dilated. This typically occurs with first-time mom who is unmedicated. They may feel the urge to push at 8 to 9 centimeters. You want to make sure that you tell them to not to push, change position, try different breathing techniques to prevent them from pushing too early so they don't have a cervical laceration. Vaginal vein tears can cause vaginal hematomas. Vaginal hematomas commonly occur with instrumentative delivery as well as laceration. So anytime forceps or the vacuum is used, it can increase a patient's risk of having vaginal vein tears and leading to hematoma. The other picture to the right is a C-section incision. Bruising typically is common around the incision. What you want to know about this is the same thing applies when you're checking a vaginal or perineal laceration or tear, that you're looking to make sure the incision's approximated either with the glue or staples. There's no foul-smelling drainage or discharge. There's no bleeding at the site. It's not getting red around the site. For postpartum vaginal deliveries, their follow-up is 6 weeks after delivery because it correlates with their uterus involuting at that time. For C-sections, they follow up within 2 weeks because the physician usually wants to do an incision check. And you would provide the patient education on discharge that they need to look at their incision site every day, whether it's themselves or their partner. Wash it with warm soap and water, pat dry, no creams or lotions due to risk of infection, and then monitor for the same types of things, redness, drainage, and make sure it's still closed. So we've talked quite a bit about postpartum hemorrhage. Uterine atony, meaning muscle or the uterine tone, whether it's firm or boggy, is the number one cause of a postpartum hemorrhage. Tissue, so retained products, whether it's fetal or placental tissue. Trauma has to do with the lacerations, hematoma formation, if they had a uterine rupture. And then thrombin is more of the coagulation or bleeding disorders that a patient may have. First thing you want to do if a patient starts bleeding is to massage their fundus. If that doesn't work, then you're going to further go into your additional steps, calling the physician, giving medications, emptying their bladder. So you're going to give oxytocin, is a medication given to help with postpartum hemorrhage because it causes your uterus to contract. Cytotec, Methergin, and Hemabate are all other medications given as well. TXA is another newer one that we will give to patients to help with bleeding. You want to make sure that they have an empty bladder. So if you, despite doing fundal massage, giving meds, they haven't voided for 4, 5, 6 hours, then you want to straight cath them and empty their bladder. When we talk about oxygenation, as with the pregnant mom, you're always going to give, whether it has to do with pregnant or postpartum, you're going to give oxygen via mask instead of nasal cannula. Patient position, what position do you want these patients in? You want them laying flat or in slight Trendelenburg to help with the blood return to get to their vital organs. The best way to prevent this is identifying risk factors that the patient may have prior to delivery, anticipating it, doing your frequent fundal checks, making sure that their bladder, they're getting up frequently to go to the bathroom, and that you're checking their bleeding as well every time that you're in there doing their fundal massage, and identifying it early and treating it early. Moms still unfortunately die. This is one of the number one leading cause postpartum deaths in mom is from a postpartum hemorrhage, and it's because people didn't identify it early enough and they don't act quickly enough. So postpartum hemorrhage can happen up to 12 weeks postpartum. Within the first 24 hours following delivery, it's a primary hemorrhage. Anything greater than 24 hours is considered a secondary postpartum hemorrhage. Vaginal bleeding, normal is 500, C-section is 1,000. Anything above those, it will be considered a hemorrhage. Kind of already focused on this before. We're not estimating blood loss. We always want to quantify the amount of blood loss that a patient has. How do you quantify it? You're not just visually looking at their pads and guessing how much. You are putting all the stuff on a scale and weighing it, whether that be the chucks, the gauze, the sheets, the blanket, patient's gown, whatever they may be wearing. You need to put that on the the scale and weigh it. So I'd already talked a little bit about hematomas and lacerations. This picture up at the top here is the cervix being pulled out because they had a cervical tear that had to be repaired. Lacerations and hematomas, like I mentioned before, can be caused by instrumentative delivery, the vacuum and forceps, birth trauma, precipitous delivery. When we talked about that in your lecture for labor, that the patient delivered very quickly. Within 3 hours, the baby came out too fast, and sometimes that can cause a lot of trauma and lacerations. If the mom started pushing before she was fully dilated, or a large for gestational age or a macrosomic baby, as well as shoulder dystocia, can cause perineal trauma, lacerations, and the formation of hematomas. This picture here in the middle is a hematoma. It makes me cringe every time I look at it because you can imagine how painful this must be for a patient. And I had one recently that looked just like this. I was frequently assessing her every 30 minutes. We were drawing labs every 6 hours to make sure that she still wasn't bleeding and that the hematoma wasn't growing any larger. Most of the time, these patients, if they get a hematoma, sometimes it occurs immediately after delivery. And so they're still, if they had an epidural, they're still medicated where they can put in a Foley catheter and not feel it as much. Unfortunately, sometimes the hematoma takes a little bit longer to form, and you won't see it until hours later when they're on the postpartum floor. And they may or may not have a catheter in place already. Most of the time they wouldn't. And trying to put a catheter in these patients is extremely painful and can be extremely difficult because of all the swelling, and it hurts for us to even touch the patient. So these patients are typically medicated with stronger pain medication, primarily narcotics, to help with their pain. Just sitting there in bed every time they move or reposition, having to get up and walk and go to the bathroom is extremely painful for these patients. You want to do ice packs because that will help with the swelling. And like I said, frequent monitoring to make sure that their hematoma isn't growing. If it is, these are some of the pictures over here, what can happen to the other organs. And when they bleed, if the hematoma is growing, they still have bleeding going on internally, and it can go up into their abdomen. A lot of times patients, if they have internal bleeding, they're going to feel a lot of pain in their back or like flank area. And so you want to make sure that you're keeping a close eye on them and notifying the doctor if you're worried or concerned. Always call them and have them come over and assess your patient. This patient that I had recently that had a very large hematoma was still bleeding internally, and we could see with the frequency of labs that I was drawing that her platelets kept dropping, and she ended up getting 2 units of blood as well as 2 units of platelets to help with her bleeding. She ended up having to go back in, and they had to go in through their abdomen to figure out where her bleeding was coming from. So now we're going to talk about some other complications that can occur. These don't always have to be associated with just a mom who had a C-section, because anytime you have surgery, whether you're pregnant or not, you're always at risk of getting DVTs, which can lead to PE. AFE is an amniotic fluid embolus, and that one is only associated with pregnant patients. So even postpartum wise, vaginal deliveries can have DVTs and PEs because of the increased blood volume and the hypercoagulable state of being pregnant can increase a patient's risk of developing a DVT or a PE. So you always want to make sure that you're inspecting the patient's extremities, their lower extremities, for swelling, pain, redness. It may not be in both legs, it might just be in one. So we already talked about at your clinical about Homan sign and why we don't test for the Homan sign anymore, because the accuracy has been disproven in studies. You can have a positive Homan sign and not have a DVT, as well as have a negative Homan sign and have a DVT. So typically we don't perform the Homan sign. And another reason is DVT in pregnant patients or postpartum patients tend to be higher in the leg. So more up in their thigh instead of their calf area. So real quick with a PE, some of the signs a patient might see who develops a pulmonary embolus is dyspnea, diaphoresis, or they're going to become diaphoretic, severe hypotension, so their blood pressure is going to drop, as well as chest pain. Those are the initial early warning signs. Also, their oxygen saturation is going to be extremely low, sometimes even down in the 80s. They're going to be, their color is going to drain in them as well. And sometimes PEs, I had a patient who was like coughing up blood, so she had bloody sputum, which is another sign of PE. But the main ones are dyspnea, diaphoresis, hypotension, and chest pain. So amniotic fluid embolus is a true medical emergency, and it's sudden onset. Most of the time you cannot predict this. It just occurs suddenly. It can occur during pregnancy, but it's very uncommon. Most of the time that it occurs is during the postpartum phase. It's also termed anaphylactoid syndrome of pregnancy. So physiologically speaking, technically you cannot say whether or not a patient has had amniotic fluid embolus unless the patient is no longer living. This condition is a whole body anaphylactic response. So why this occurs or how it occurs is the amniotic fluid somehow enters into the maternal circulation. And remember, the amniotic fluid has a lot of debris in it. It has fetal cells and hair and tissue. And so when that gets into the mother's blood, it causes like this inflammatory response because it's considered foreign. What are some reasons this could happen? An abruption. So if they had that disruption from the placenta and the uterus. Trauma can also cause amniotic fluid embolus to occur. So once these organisms, the stuff that's in the fluid cell or the fluid, amniotic fluid, gets past the heart, your body recognizes it as being foreign, and it causes your body to start attacking. This is one of the conditions that can cause a patient to go into DIC. GI meds are given to treat because of the prostaglandins and the cascade that happens in this inflammatory response. They're going to be extreme shortness of breath and lose consciousness fairly quickly once this occurs. So there's a somewhat of an automatic hypotensive shock that these patients go into. If they are pregnant, this hypotensive state affects the fetus because there is decreased perfusion to the placenta. So it can cause hypoxia in the fetus, and you're going to see that on the fetal heart rate tracing. The baby will start having decelerations and become severely bradycardic. And if the mom isn't delivered right away, then it can lead to fetal death. So remember, anytime you have an abruption or bleeding, a hemorrhage, that can lead to DIC. The amniotic fluid embolus can happen anytime. Like I said, it most frequently occurs in the postpartum stage. It's very rare for a patient to survive an amniotic fluid embolus. When you have an embolus, it can also lead to a stroke. So a lot of these patients suffer stroke due to cerebral infarction. Meds, like I said, a lot of the medications we give, Benadryl is one of them. I can't remember the rest off the top of my head. You don't need to know the medications that we give for this, but the increased response time and giving the meds right away has led to an increased survival chance for these patients. So now let's talk about infection or postpartum infections, endometritis. If the chorion, and remember the chorion is your placenta, and the amnion layers, which is your amniotic sac, disappear, so you're no longer pregnant, what gets infected? Your uterus. So endometritis is infection of your uterus. This can happen from bimanual massage, so if the doctor has to go in and massage the lower uterine segment because of a boggy uterus or postpartum hemorrhage, that can increase the risk. Numerous vag exams, poor technique during the vaginal exams, poor pericare can increase the risk of a mom having a postpartum infection. Typically for these moms, they're going to have abnormal, foul-smelling vaginal bleeding, and the patients are going to feel really, 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 really sick, and they're going to look sick. They'll also have uterine tenderness, so every time you touch their abdomen, not just when you're massaging their fundus, they're going to be in a lot of pain. These patients will also typically have a fever, and so these patients are typically treated with IV antibiotics and then sent home with PO antibiotics. I forgot to mention previously about epidural sites as being part of a patient's postpartum assessment. If a mom had an epidural, you also want to inspect their site to make sure that there's no bleeding, no drainage. Drainage I'm talking about, it could be an infection or clear like spinal fluid leaking from their site or swelling around their epidural site. They can get infection from having an epidural, which can lead to meningitis. Another thing that can happen with epidurals is patients sometimes can get a spinal headache, which can be caused by an underproduction or change in the amount of cerebral spinal fluid. Typically, this can occur, especially if they went too far and didn't get it into the epidural space. And these moms will need to have a blood patch because they will have an extremely, extremely excruciating headache every time they sit up. But when they lay down, their headache goes away when you lay them flat. So that is one of the telltale signs that a patient has a spinal headache, is if when they're sitting up, they have an extreme headache, but it goes away with laying down. The anesthesiologist is the one that would come and do the blood patch, and I'll talk to you a little bit more about that in class and explain it in a little bit more detail. So now we're going to talk about postpartum mood disorders. Those are very, very important. Every mom postpartum gets screened for postpartum depression prior to going home. What is normal? What's baby blues? And what could be postpartum depression? Typically with baby blues, it only lasts 2 weeks, and that's because it has to do with a lot of the mom's hormones. They're not getting enough sleep. They worry if they're doing everything right. They're waking up frequently to breastfeed, and it can be difficult sometimes with breastfeeding, especially if it's not going well. And it just takes them a little bit longer to adjust to being a new mom. If it lasts past the 2 week period, then that is when you start worrying about postpartum depression. They're having trouble sleeping, they're having trouble bonding with the baby, or they're not caring for the baby. They don't want to talk to anybody or their friends. Just have a different change in their lifestyle and how they were and their moods previously. So typically postpartum patients are tired. They're exhausted, but they're also happy. So you're going to be a little more emotional than usually due to all the hormones. You might feel overwhelmed, but you're able to manage it. So the Edinburgh Postpartum Depression Scale is a scale we use in the hospital to screen all patients. You need to know prior to delivery if there are risk factors, if they're already having depressive symptoms, or if they have a history of postpartum depression. Then they're at higher risk of developing postpartum depression or some other mood disorder. You want to make sure that if they score high, typically it's anything over a 12, or if the last question, which is do they want to harm themselves, they check yes on that, then social work will get involved. And they'll come and meet with the patient and talk to them and offer them resources and set up counseling for them if they are agreeable prior to going home. So this is the Edinburgh scale that we do, and this just goes over some more of the symptoms and treatment options. So here we go again with the hormones. In pregnancy, we see increased levels of progesterone. Remember that progesterone is used for preterm labor because it helps maintain the pregnancy. Prolactin is developing throughout your pregnancy. It's found in your breast at 16 weeks of pregnancy. So your body's producing prolactin for lactation. It also helps produce your milk supply. And then the oxytocin starts to kick in. And once you feed your baby, your prolactin levels go up and then drop. And when your baby feeds, it refills. One thing I want you to remember or point out with this graph is what is going on with your hormones when you're breastfeeding. So you can see that the prolactin goes up, then it starts to drop during breastfeeding. It spikes again following breastfeeding and then drops when the baby starts to feed again and increases again following. Your oxytocin is increasing during the time that the baby is feeding, whereas your prolactin levels are decreasing. Your progesterone falls off after the mom. It starts to slowly decrease, as well as the estrogen once the patient gives birth. And oxytocin helps with milk letdown. And 90 or sorry. So you learned about some of the breastfeeding positions at your clinical. These are just the different positions you can use. Cradle, cross cradle, and the football hold are probably the most common ones that are used in the hospital. Once your baby starts to get more experienced and is better at breastfeeding, then some of these other positions, the side lying or back lying, can be used once you get home. So breastfeeding latch. 90% of breastfeeding issues occur with the problem with the baby latching on appropriately. If the baby does not empty the breast, the body will not produce more milk. So you want to make sure that they have a good latch. Engorgement is a normal postpartum process. Typically, it takes your milk 3 to 4 days to come in. but you do have colostrum. Colostrum is extremely high in fat, proteins, calories. They're small amounts, but it is very thick and it's very beneficial for the newborn. Remember that regardless of whether you carry your pregnancy to term or not, or you have a fetal loss, that every woman lactates. So it's important that you teach these moms about breast care. Moms who have had fetal loss, as well as moms who don't want to breastfeed and just want to bottle feed. Some things that you can do to help dry up your milk is putting cabbage leaves in your bra. That will help. Also, it helps dry your milk up, but it also provides comfort. You can take Tylenol because a lot of times it'll be painful when your breasts get engorged and before your milk dries up, and you can also develop a fever, a low-grade fever. You should wear a tight-fitting bra and avoid hot showers. So you don't want to do heat. You don't want to cause nipple stimulation, because that will help increase your milk supply instead of drying it up. 5 mLs of colostrum, which isn't very much, can increase a baby's glucose level faster than 30 mLs of formula. So if you have a mom who had a preterm baby, typically their babies are in NICU. So moms can still give their newborns breast milk, even though they're not able to may not be able to breastfeed them, by pumping. They also have donor milk that we can provide to patients if they, for whatever reason, are having issues with breastfeeding. They are not able to produce their own milk or enough milk to feed their baby. They have donor milk available. So if you place warm compresses on a patient's breast, remember, heat brings your milk in, but cold compresses help dry up the milk. So if you have engorgement, it can be very painful. You want to do ice packs for 10 to 15 minutes every hour to help with comfort. Wearing the tight-fitting bra, avoiding the warm showers, Tylenol for pain. Decrease the nipple stimulation. Clogged ducts can occur if your milk is not emptying, and it can lead to mastitis, so a breast infection, which is a form of staph on your skin. You usually will see redness. You can see the outline of the clogged ducts. Sometimes it occurs in streaks. There is a misconception on the size of the breast. Your size of your breast does not matter. You can still produce milk. So you don't want to breastfeed with MRSA, but you can if you have mastitis. It just depends, physician preference. The pediatrician or your doctor may encourage pumping until your breast infection clears up. So here's what I was talking about with the inflamed breast tissue. Typically, you'll see that red streaks, and their breasts are very, very hard and very painful. So breast versus formula feeding, you want to educate your patients on breastfeeding, as well as if they choose to bottle feed, and then ultimately is up to them and their choice whether they want to breast or bottle feed. Shouldn't pressure patients into breastfeeding if they have no desire to do it. Breast milk changes with every feeding, and it adjusts to the needs of the newborn. So, if you had twins, it would adjust for each individual baby that you had. So, if one baby is too cold and you're breastfeeding, your body automatically will heat up the milk. If the other baby is too hot, then it cools the milk, which is one of the cool things that our bodies do. Our bodies do so many amazing things. One thing I wanted to mention is that while you're breastfeeding, you're discouraged of using any substances, illegal substances, or alcohol, drinking alcohol while you're breastfeeding, because your blood alcohol level is the same as the level in the breast milk. So if you're having an extremely high blood alcohol level and you're breastfeeding your newborn, then that is the same level that you have in your body is going to them, and they're much smaller, and so it's going to have more of an effect on a newborn than it would on an adult. If you're sick, you should still breastfeed. They encourage you to continue to breastfeed because those antibodies that your body is producing will be passed on to the newborn. Gas can occur in babies whether you're breastfeeding or formula feeding. So you want to make sure that you educate your patients that they still need to burp their babies even if they are only breastfeeding. Babies typically manage their own feeding. They do not overeat. They're more comfortable following delivery, less spitting up when you let them control their own feed, so you don't want to overfeed. And you learned about this in clinical, how small the newborn's stomach is and how much they need to be eating. And it's important to educate your parents on that and even show them a visual so that they know and understand, because a lot of parents have that misconception that their baby's not getting enough milk because their milk isn't in. How do you know if a newborn's getting enough milk? Well, they're going to be having wet diapers and poopy diapers, and so you're going to be monitoring how many diapers they have. As long as a mom is still breastfeeding, you want to encourage them to keep taking their prenatal vitamin. They need to increase their caloric intake as well as their hydration. So they need to drink more water, because every time they breastfeed, it's going to be taking nutrients and calories and hydration, and can cause moms to be dehydrated if they're not keeping up with their water intake. So preterm babies under 34 to 34 weeks typically have issues with sucking, swallowing, the whole breathing process. They have a hard time coordinating all of those together. And so they may choke or aspirate if held upright. So you want to lift the baby up and feed horizontally, which is referred to as baby-led feeding. This can also prevent colic if it is true colic. And so burping is the key again. You want to make sure that you're always burping after feeding. So breast versus bottle stools, you guys got to kind of look at the different changes that occur whether mom's breastfeeding or bottle feeding. The formula fed is more seedy-like because the stomach processes proteins in the formula. They cannot break them down any further. If you have a baby who's taking iron, it's going to be more of this darker green. This is bloody stool. We don't typically see bloody stool. It's not a normal finding. So if you're if a newborn has bloody stool, you want to make sure that you report it right away to the physician. Diarrhea can occur. A lot of babies who go through withdrawals from substances have diarrhea. Meconium is the thick, tarry type that occurs within the first 24 to 48 hours of a newborn's life. Typically, breastfed baby, their poop's going to be like a mustard yellow, and it can be seedy and pasty in texture, kind of even a little bit runnier, where the formula fed is going to be a yellowish brown with more of a pasty consistency, kind of like peanut butter, so it's a little bit more firmer than with breastfeeding. When we're talking about newborn feeding cues, it's important to pay attention to your baby and when they are hungry or not. So you don't want to wait until you get to the late cues, because then they're very upset and it's going to be very hard to feed them at this time. You want to watch for the early cues of when they're kind of getting restless, they're opening their mouth, turning their head, and seeking and looking and rooting, looking for the nipple. Then they kind of start getting even more restless and in more movement, and then they start sucking on their hands or putting their hands to the mouth. By the time they're crying and they're having agitated body movements, they're turning red, they're very upset, and they're very hungry, and it's going to be extremely hard to feed them during this time, because they're going to be so upset that they typically won't eat. So you want to make sure that you feed them as soon as you start seeing the early signs. We've already talked a lot about skin to skin, educating on different safety things. So if you're pumping because you have a baby in NICU, you're going back to work, you want to make sure that you're cleaning your pump every time, that all the pieces, that you're washing your hands, that you're not putting stuff on your nipples or breasts prior to feeding. You can use Lansano that helps keep your nipples moist and prevent them from cracking. But prior to feeding, you want to make sure that you wash the Lansano off. They just say use water, don't do soaps, because that will dry out your breast and nipples. Skin to skin can cause or can have numerous benefits. It helps with temperature control, stabilizing a baby's blood glucose. It helps with bonding. It increases breastfeeding success. There's so many different things that skin to skin can help with. And not only the mom can do it, but also the dad can do skin to skin as well. And so here's a couple more things that it can help with. Milk production can help decrease the chance of a mom having postpartum depression. It helps with brain development, it helps the baby sleep better, it can regulate their heart rate and breathing. And then it increases oxytocin production in the mom, the father, as well as the newborn. And oxytocin is referred to as the love hormone. And so that's why it also helps with bonding. So during the postpartum, while a mom is admitted in the hospital postpartum, there's a lot of education that is provided to parents, especially first time parents, on all the different things to do, watch for, and even when they get home, with both themselves as well as the newborn. You need to talk to the parents about changing their diapers, monitoring how many wet and dirty diapers they have in a day, bathing, cord care. There's not really anything that we do with cord care anymore. We don't put alcohol on it to dry it out. Fold the diaper down because you don't want it covering the umbilical cord until it falls off. Bathing initially until the cord falls off should just be sponge baths. You shouldn't immerse them in a bathtub. And then once the cord falls off, then you can do tub baths. Need to talk to them, make sure they have a car seat. Um, they don't recommend using baby powders because of the risk of asthma and getting too much and the baby's inhaling it. And limit the lotions and other things that you're putting on the baby, because those can cause, especially the fragrance ones, can lead to newborns having allergies later in life. So SIDS prevention, safe sleep, and shaken baby syndrome, those are all things that we talk with parents before going home as well. There's a video that's provided by the county health department on the shaken baby syndrome. And then there's a video that they also have to watch before they go home on safe sleep. We want to discourage co-sleeping. With SIDS, they're not sure why it occurs, but sometimes, or it's been found to be associated with low socioeconomic status and ethnicity. Not sure of the correlation. They don't really know. But things you want to make sure to do to prevent SIDS is creating a safe sleep environment. So you want to make sure that the mattress you're using is firm, that the fits tightly in the crib. There's not space between the crib rails and the mattress. You want to make sure that you're using a tight fitted sheet. You don't want any toys, stuffed animals, loose bedding, fluffy blankets wrapped around the baby, because those are all things that can increase the risk of a baby dying from SIDS. So, with shaken baby syndrome, it's basically a concussion, frontal lobe, and to the back of the brain and the brainstem. So, just like if you were involved in a motor vehicle accident where your head kind of falls forward and then jerks back very quickly, your brain is getting shaken around inside. And this can lead to subdural and subarachnoid hemorrhages in the baby's brain. So basically, brain damage. And so you want to educate the patients that if they get overwhelmed or if their baby is crying and they're getting frustrated, that they need to put their baby down. Put them down in a crib, shut the door, go walk around, calm down, get yourself situated before you come back and pick up the baby again, because sometimes it's that natural reaction when you get frustrated to start shaking, and you want to make sure that you're not holding the baby to prevent this from occurring. You will cover the shaken baby syndrome more thoroughly when you get to peds as well. Um, there's also that common misconception that babies get spoiled if you're picking them up and holding them all the time, and every time they cry, you go and run to them and want to pick them up. So, crying it out for a newborn, it doesn't help the baby. They're instinctual creatures. So if they are crying, there's usually a reason. It could be because they're in pain. It could be because they have a wet or dirty diaper. It could be because they're hungry. So you always want to make sure that you're looking for reasons why your baby's crying. Maybe they're crying because their belly hurts. They have gas pain. Um, so you always want to make sure that anytime the baby cries, that you're investigating why they're crying. When babies get overstimulated, they play dead almost, where they get really calm and quiet and don't move much. And so you want to prevent overstimulation in newborns as well. This little box down here is a sleep box. Some hospitals give those out for parents who don't have a crib and for a safe place for the newborn to sleep so that they're not sleeping in the bed with the parents. So here are some of the warning signs that we talk to moms about: post-birth warning signs, when to call 911 or when to call your doctor. If you have pain in your chest, difficulty breathing, shortness of breath, have a seizure, or thoughts of hurting yourself or your baby, you'd want to call 911. You would call the physician if your incision's not healing, if you have a red or swollen leg that's painful or warm to the touch, if you have a temperature, a headache that does not get better even after taking Tylenol, or visual changes that has to do with preeclampsia. And then if you're bleeding, soaking through a pad in an hour, having blood clots, this is the size of an egg or bigger, we say golf ball, um, then they need to call their physician, because that's too much bleeding, and they would probably have them come back to the hospital to get checked out. So when we say make them do it, how most people learn: you see one, do one, teach one. So you get everyone involved, not just have the mom do it, but also the dad. Have them, show them how to change a newborn's diaper, what things to watch out for, looking at the cord, how to take their temperature. And babies we take their temperature axillary. um, make sure that they have support and help when they get home, that they have a pediatrician picked out, and that um, if their OB provider, say they had an emergency delivery and they delivered at a hospital that wasn't their regular OB, that they follow up with their own OB once they get home. And accept help. You're going to be tired. You're going to be overwhelmed. You're going to be caring for your baby and might not have time to cook or prepare meals. So accepting help from family or friends, whoever can bring you food, or if you want to take a nap, come and watch your baby so that you're also getting the rest that you need. Birth control, breastfeeding, remember, is not a form of birth control. So you want to talk to the mom about birth control prior to leaving the hospital. Also, parents should, or moms should, wait at least a year before getting pregnant again to allow their body to heal and rest. Because if they get pregnant too soon, sometimes they're more at risk of developing complications. Um, Also, educating them on when it's appropriate to have sex again after delivery. Typically, we say 6 weeks, no birth or no douching, no tampons or sex until 6 weeks postpartum. The reason why 6 weeks is set for most of it is because that's when you're going to go and follow up with your OB physician and make sure that everything is okay. So that's the end of this lecture. In class, we're going to talk more about some pelvic relaxation disorders, because a lot of those problems can occur following delivery. So we'll talk more in depth on those concepts and medications used to help with those in class, as well as I'll have a a smaller version of a PowerPoint. There'll only be a few slides, and I'll post that in the postpartum Q&A as well.